Dr. Abittan, welcome to this evening's webinar. And let's begin. Dr. Abittan, there are so many people. I mean, there are well over 100, close to 200 people that registered for tonight's webinar. And what that tells me is that there are many people out there who are interested in hearing about the intersection between halacha and fertility. And very often people get carried away in like the big complicated issues, how do we determine motherhood and surrogate pregnancies and whatnot. But all too often we seem to overlook the basics in terms of getting pregnant, basics in terms of IUI and IVF, and what are some of the classic, like the good old halachic questions that come up with every single person's fertility struggle and fertility journey. So let me ask you a question, Dr. Abittan.
Sure.
When it comes to your center, when you begin meeting with patients and consults and whatnot, so what are some of the halachic issues that you, from your perspective, that you kind of tell your frum patients about when they come and they know nothing, right? If they were looking to you as a frum physician, what are some of the things that people are nervous about? What are some of the things that you in your practice are talking to people about? And then we'll from there we'll take the conversation ahead. So let's hear some of those issues that you feel that you experience in your practice as a frum physician, and then we'll take it from there.
Sure. Thank you, Rabbi Silverman. This is definitely something I'm very passionate about and something that we deal with on a daily basis. So first, I want to preface that this does come up a lot with patients, and certainly being a frum doctor, and there's a number of frum doctors in our field, but being a frum doctor in our field, it does come up a lot. So it's important to just preface, I always tell patients, I'm not a rabbi. I can't tell you what to do, what not to do. People say, what do most people do? I can't tell you what most people do. What I can tell you is what the issues are, if someone is not already aware. Now, we love the educated consumer. So we love when someone kind of already knows what some of the issues are. Certainly anyone that's, speaking to PUA, for example, will already know, these are, the couple things that I'm dealing with, and these are the salient issues. And we love when someone has already, addressed some of those. But if let's say there's a patient or a couple that is wondering how halacha will intersect, so it's definitely tailor-made. It's very dependent on what exactly is going on. Some of the big key issues that can come up without getting into, large, fancy, big headline topics. But some of the common day-to-day issues are, number one, how this intersects with the zmane of nida and tahara. And so certainly depending on one's cycle, where someone ovulates in their cycle can affect the ability for conception. And when the ability for conception is dependent on various times in the cycle, sometimes someone's cycle might be longer or shorter. Ovulation could happen before the mikveh, very far outside after the mikveh. And sometimes there's simply a timing issue or an inability to have a real opportunity for pregnancy just based on how one's cycle works and how that interplays with the halachos of nida. And so that's
let me stop you right there. How often do you see patients, and after the consultation, after listening to them and reviewing their chart, how often are you able to say, hey, wait a minute, I think that there may just be a timing issue. She's ovulating, his sperm is okay, but I think it's just what we'll call early ovulation. How often does that come to your desk?
Sure. So it's less likely than it used to be. And the reason for that, and I've only been in the field, I'm talking in terms of our field's history, not my own personal history. It's less likely than in our field's history because nowadays, largely all the poskim in the 90s and even in the 80s and the 90s and the early 2000s all spoke about what to do when there is early ovulation, and ovulation happens before going to the mikveh and everything else is fine, and everyone had to grapple with that issue of what to do. Nowadays, with modern hormones that we've had for the last 40 plus years, it's pretty easy to address that, to give a little bit of a certain type of hormone called estradiol or estrogen at the beginning of the cycle. There's multiple different methods of giving that medication, and we're able to just delay for 95+% of cases in this scenario, we're able to just delay ovulation to after going to the mikveh. Now, this is something that it used to be that reproductive endocrinologists or fertility doctors were doing more, but it's become much simpler. And over the years, OBGYNs, general OBGYNs, are doing this all the time. Most cases of women or couples that ovulation is happening prior to the mikveh, the OBGYNs are dealing with. And so I would say nowadays, in terms of, let's say, my patient population, it's probably less than 10% of the time that it's really just going to be at an initial consultation. Obviously, there are times that we know about it in advance. It's not working, whatever they're doing at home. And so therefore they're coming in for the, let's say, the next step. But at a baseline, no one's ever done anything, not tried estrogen before, not being taken care of by their OBGYN. It's pretty low, 5 to 10%, I would say, where it's simply the timing of ovulation as it relates to being too fast, meaning earlier than going to the mikveh.
Understood. So let's say we're dealing with couples that have had a few cycles of estradiol with their OBGYNs, and let's say they've solved the early ovulation issue. Now it's just unexplained.
Sure.
So here they are, Extend Fertility, Dr. Baruch Abittan, unexplained infertility. What's next? Should you, let me ask you a pointed question. They've heard about medicated cycles going on letrozole or Clomid and timed intercourse. They've also heard about something called IUI, an intrauterine insemination. Mm-hmm. So if they pose that question to you, is there real advantage of an IUI over medicated cycles or timed intercourse? How would you respond to that? And then we're going to get a little bit more in depth in the IUI world.
Sure. So this is it's an interesting question. I think you're probably doing it b'kavana and asking that question in a very specific way, because I don't know how many people are on or who's listening, but for
thousands,
Dr.
Abittan.
For the
thousands of people listening to this.
For the thousands of people that are on and that are listening, for all that know, obviously Rabbi Seligman deals with this every single day. So you're fully informed on the ins and outs of the medical side. So I think that question was very, very pointed. So I'll address it. The way to address that question, it is a debate, so it is not fully resolved, but I'll try to explain it like this. If someone was working with their OBGYN and doing estrogen for a couple months in a row, let's call it 6 months, where they were presumably having good ovulations and everything going well, and it was after the mikveh, there should be no issues, and yet pregnancy hasn't happened, and you're otherwise young and healthy, right? So first we need to confirm, is it truly unexplained infertility? So the rabbi used the terminology unexplained infertility. Technically, at this point, we don't necessarily know that it's unexplained, but I'll define unexplained infertility. So unexplained infertility is a pretty frustrating terminology, but it's a terminology where the very, very basic testing is coming back normal. We don't know exactly why pregnancy hasn't happened yet, but you have a couple that technically ovulation is happening. It's happening well, strong, at the right time with ability for pregnancy. Both tubes, fallopian tubes that connect to the uterus, are patent, meaning that both tubes are open and seemingly functioning well. That there is adequate and good quality sperm production, that the counts are good, the quality is good, and that they're seemingly have the ability, meaning the right time of the month, to be able to meet. That's the very, very basic testing. There's more advanced testing. That's a very basic testing that's able to be done. And once that testing is all completely normal, and yet pregnancy doesn't happen for someone who's below 35, it's actually officially a year. And for someone who above 35 or above would be 6 months, we would deem that unexplained infertility. So what the rabbi's question was, and the point was, is that if someone truly has unexplained infertility, in that scenario, sperm counts are normal, would IUI be helpful or not? So the first thing I would address is when someone has done those 6 cycles with their OBGYN and they're coming to us. So we take that, it's very important, to know that those cycles existed. But I could tell you countless times where a couple, let's say, didn't want to do any further testing or whatnot, or we said, you know what, let's just try 1 or 2 months of taking Clomid or even doing estrogen by ourselves and monitoring that cycle to time things a little bit better, to use a trigger shot to get a good, strong ovulation at the right time. And there have been countless times that all we did was another estrogen cycle, but with monitoring, and pregnancy happened, right away. That could be because it just took an extra month or two. That also could be that, there's still an advantage to some form of monitoring for someone that pregnancy is otherwise not happening easily, because when it wasn't being monitored, you never know 100%. You're relying on ovulation prediction kits. They don't work for everyone. But let's assume that we did all those cycles, and we know that you did 6 cycles, 7 cycles, whatever that number is, to deem someone as unexplained infertility, and sperm counts are normal. So the jury is somewhat out. Technically, when sperm counts are normal, it should work. But if it's not working and it's unexplained infertility, so the data actually does show us. Now, Halacha will have what to say, but at least from a scientific medical standpoint, once someone has proven unexplained infertility, the data shows us that just doing Clomid or letrozole, which are the medications to stimulate ovulation, just doing that and having regular timed intercourse, just timing the right time of the month at home, might mildly increase pregnancy rates from baseline with unexplained infertility, but not very significantly. And maybe just adding an IUI also might not change it too much. But officially, doing Clomid or letrozole and an IUI together will significantly increase the percentage chance of pregnancy per month. That's what it shows us in the studies. That's what it shows us scientifically. It also makes sense logically, right? Is that if all the testing is normal, why are we only focusing on you, meaning the wife, right? Why are we only focusing on her if everything is normal? It could be there's a black box between the time that a couple is together naturally and between there's like an implantation happening at some point 5 days later. So is something going on with the sperm counts? Is something going, well, not the sperm counts, but is something going on with the sperm being able to survive the vaginal area? It has to get into the cervix. It has to make its way slowly through the cervix and into the uterus. Egg and sperm have to be able to meet, etc. And we know very small percentage actually makes it all the way there. There could be things along the way, untestable, right? And so logically and also medically, if someone truly has unexplained infertility, we would presume that adding IUI would help.
So here really begins a couple's real one of their first shilas. If they haven't already done a semen analysis, so then they'll start inquiring about a semen analysis. At what point in the cycle should they get a semen analysis? And what part of their journey should they get a semen analysis? From a halachic standpoint, I'm sure from a medical standpoint, from the moment they put their left foot in the front, in their office door, there should be there's a collection cup, and why don't you get your semen analysis ready?
Absolutely, I could tell you, obviously not us as from doctors, but I could tell you that the convention of teaching and what's in the textbooks, what's in the guidebooks, is the first thing anyone does is a semen analysis. It's so easy to do,
right?
And
correct.
So, and it gives you so much information. That's the first thing. Obviously, we don't do
correct.
that.
And the truth is, and halacha doesn't discount that. It's just that there's a different perspective when the female testing doesn't compromise any question of halacha whatsoever, and the male does. So then it's just a matter of checking off some of the boxes and making sure that we've tried to identify an issue without having to even talk about halacha. However, we would never feel that a woman should go through everything in this test and that test and this test and really, go through all of the vigorous testing without recognizing the male, especially with relatively recent findings and what I think is understood as medical reality, that it's a 50% chance. In other words, 50% of the time it's a female issue and 50% of the time it's a male issue. So it's a pretty significant number. We're not going to ignore the male. Certainly when it comes to an IUI, the male needs to obtain a semen sample with timed intercourse, with monitoring. So they're having regular intercourse, having regular tashmish. and they don't have to produce any semen samples. However, comes the time for an IUI, the doctor says that's really the next best thing. So I'm going to give you two options, Dr. Abittan. I would love to hear your opinion. So some
Sure.
Rabbanim tell couples that the way they should obtain a sample is to having regular unprotected intercourse. And after intercourse, after ejaculation, the woman takes a sterile collection cup and she collects the sperm, she collects the semen that was ejaculated, and she collects it in the cup, seals it, brings it to the lab, I don't know, within an hour and a half. That's really up to the doctor. And the doctor takes that sample and uses it for the IUI. Another method of procurement would be a medical condom, a male factor collection condom. Normally, condoms come with spermicide. They're laced with spermicide, ones that you buy in the pharmacy, let's say. But these special medical condoms come without any spermicide on it whatsoever. They produce in the condom, and then they bring the condom to the lab within an hour and a half, whatever the doctor tells them. Dr. Abittan, I will present to you the following question. Should a patient be doing one method over the other from a medical standpoint? I'll deal with the halacha, you deal with the medicine. From your medical perspective, do you feel like both samples are equal samples? What do you now normally recommend patients? We'd love to hear that, and then can continue the halachic discussion.
So it's a good question, putting me on the spot. So it's very difficult especially with this point, it's very difficult to separate the medicine and the halacha. But what I'll try to do is address the nuances of this scenario. So if a couple is doing IUI and the sperm counts are really so strong, and excellent, maybe they're doing IUIs for unexplained infertility. It could be.
Let's assume they've reached that point where they just haven't gotten a pregnancy.
But the sperm counts are fantastic.
Let's assume.
And there are times that using what we'll call it the cup collection versus, let's say, the condom collection, so that there are times that using that cup collection it suffices. You'll get enough, there'll be enough sperm. There won't be bacteria if you do it following the exact guidelines of a good collection, and we get pregnancies from IUIs with cup collections, right? So certainly proof is there in the pudding. It can absolutely work in the right situation and scenario. The challenge comes when we know that most is not going to make it out into that cup collection. And so it's really only a portion of the actual semen that is able to make it in. And if the sperm counts are anything but fantastic, usually a cup collection is going to give very, very low counts. It is very common that when a cup is used for an IUI, it's very common that the numbers are pretty low for IUI. So if someone's doing IUI because of medical necessity, forget unexplained infertility for a minute, that the sperm counts are low. In a scenario with low sperm counts, in general, a cup collection will be a major problem. In a scenario of unexplained infertility with fantastic sperm counts, technically a cup collection can work. Just to put it into perspective, from regular natural tashmish or intercourse at home, the numbers that we would want, of course, it only takes one sperm, right, to cause a pregnancy. But b'derech hateva, we would want someone to have, let's say, close to around 20 million moving sperm. Every time a couple is together, at least 20, it sounds low, but it sounds high, but it's not. It's pretty low. At least 20 million moving sperm cells to have a good chance b'derech hateva of a pregnancy, right? But once you're preparing something for an IUI, after it's washed and cleaned, we need between 5 to 10 million moving, right? So just if you imagine, right, if someone has 150 million moving sperm and they do a cup collection and get only a portion of that, and then they wash and clean it and it'll still only have a portion, they'll probably still be totally fine for an IUI. The data on IUI is once you're above 9 million total modal sperm, you probably don't get any benefit by being 13, 15, once you're above 9, 10 million, that's pretty good. And so it can work for some, but for many, the cup collection can pose problems.
And what about for a semen analysis? What's your perspective in terms of, we haven't even gotten to the IUI. You know,
Sure.
you just met me.
Most common, because the most common question is semen analysis, right? At what point do you do the semen analysis? When can you do the semen analysis? And if you are at that point that you can do the semen analysis, how can you do the semen analysis? Do you start with a cup collection? Are you able to do the condom collection?
Yeah. So let's hear your medical opinion. I'm not on when, you know, but on
Yeah.
how.
Yeah. When, that's up to Halacha. Whenever the Halacha will allow it is a good time to do it. It's not always medically necessary. So for many couples, when they're just starting out, I'll tell them, you know, you don't really have to do, even medically, you don't have to do a semen analysis yet. But at a certain point, once it becomes medically important, the earliest Halacha will allow it, the better, because sperm doesn't get better overnight. So if there's a problem that you want to deal with, you're looking at like a 5 to 6 month journey of trying to improve sperm counts if you even go down that path. So once halacha allows it, it's better to know sooner than later. But in terms of how to check sperm, so there used to be, and there are some doctors that still do it, not really fertility doctors, but there used to be that and there's one question about clarifying what I mean halacha allows it. I mean that the Rav or the rabbi, that couple is asking and discussing for their guidance of every step of the way, will say, you know, now is halachically appropriate time to go forward with the semen analysis, or you should wait a little bit. But once that is okay, there are various methods of doing it. So I'll say, like, let's say 3 sort of methods that the frum community will use. So method number 0 to 1, we'll call it, because it's sort of phased out. Certainly fertility doctors are not doing it, but there are still some OBGYNs, and it's a useful tool, is the PCT, or the postcoital test. And that is what you see in all the old books and all the old Sfarim. And so the PCT, or the postcoital test, will be after a couple is together naturally at home. The woman will come in to the doctor's office a couple hours later. They'll do a swab of the cervix and take that swab it on a slide, and look under the microscope to see if there's countless, you know, moving, swimming sperm. If it's positive and it looks great, that's fantastic. You still don't know an actual number, but it'll at least say, oh yeah, the sperm counts look good. And if it raises any concern, that could be a potential reason to want to do a semen analysis. The PCTs, even in the 90s, a lot of the data found that it correlated basically 0% with pregnancy rates. So there was no correlation between PCT and pregnancy rates. They started falling out of favor. Really, only the people that were doing it were OBGYNs helping the frum community, because that was sort of an initial easy way without any real halachic shaila of getting data regarding the sperm counts. Those have since mainly fallen out of favor, but now we have the 2 that Rabbi Segelman mentioned. Number 1, which is that cup collection, where a couple's together naturally, and about 10, 15 minutes later, you know, she'll stand up and let whatever was going to flow out naturally over the next day or 2 just to start coming out, collected in the cup, bring that into the lab. Or is the the condom collection, frequently with, let's say, some sort of hole poked in it that could still technically allow pregnancy to happen, but that Rabbi Segelman can address, you know, yes hole or no hole. But essentially, that condom collection, technically, from a medical perspective, will be a better collection no matter how you slice it, right? It'll get the entire sample. It'll be sterile. It'll be just as good as the best type of sperm collection possible. The cup collection, if it is good, meaning if all the parameters come back perfect, we know everything is fine. However, it doesn't have a very, very strong negative predictive value, meaning that if there is some concerns from that cup collection, it doesn't necessarily mean that the sperm counts are bad. But I'll get a little bit more nuanced, is that there's a few factors that we look at when it comes to a semen analysis. We look at the volume. Volume won't be similarly accurate with a cup collection, because we know we're only getting part of the volume. So that's okay. We look at the sperm count. But when we say sperm count, we're not thinking about a sperm count. We're thinking about a sperm concentration. And what concentration is, how many millions of sperm cells per milliliter of the semen or the liquid that we're actually measuring. How many millions of sperm per milliliter. And so many times, now we haven't looked at the data, we're considering it, But many, many times the concentration on a cup is actually pretty accurate. Because again, it doesn't really matter what the volume is, it matters what that concentration is, how many millions per ml. There are plenty of times that it's not accurate, but out of everything, that's something that is usually somewhat correct. Motility is always wrong. Motility is always wrong because a lot of the sperm that's sitting in the vaginal area before it gets collected is going to get killed off by the various situation. And so that is not going to be accurate. Okay. But I'm not worried about that. When we see a low motility on a cup collection, we know why. Mm-hmm. So from a cup collection, if it's good, it's excellent. It absolved needing any other testing, and we know it's fine. And that happens from time to time. If it's bad, it depends kind of what's bad, and then we'll sort of counsel a couple. If it's halakhically better, which most and many hold, it's a great first option because it at least gives us a look. We can see, is there sperm? Does it seem low or does it seem very, very high? Is the motility, it gives us a lot of information that we never would have gotten from a PCT. And clearly it's seemingly better halakhically. And so it's a very, very good first step. It doesn't give us everything, but it's a good first step.
Great. Let's move on to Shabbos. Couple is doing IUI. They're monitoring the patient. And the doctor comes into the office and says, or the nurse calls, however the system is set up, it looks like the best day for your IUI is on Shabbos. Phone rings at Pua. I was just told my IUI is going to fall out on Shabbos. What do I do? So Dr. Abittan, does an IUI have to take place on Shabbos? If a doctor tells a patient that the IUI is supposed to take place on Shabbos, can it be done on Friday? Can it be pushed to Sunday? How specific is that window of time that we talk about the best time for an IUI?
It's very, very, very rarely that an IUI could only be done on Shabbos. I would love to see that chart and the levels and the numbers. I can't tell you how infrequent, if ever, that we've ever made the recommendation to do an IUI on Shabbos for a few reasons. Number one is, well, if you're somewhere that cares and that's thinking about it. So it for sure could fall out. Again, if it's one of the days of the week, of course an IUI could fall out on Shabbos routinely, just like
it could fall out on a Tuesday or a Wednesday.
Now, within reason, obviously no fertility practice wants to just add things on weekends, right? No one likes doing things on Shabbos and Sundays. They would like to minimize that as much as possible, other than things that are absolutely necessary. But any busy fertility practice is doing a bunch of IUIs on their Saturday, doing a bunch of IUIs on Sunday, whatever the case may be, right? But it is unlikely that it needs to be on Shabbos. So if someone's thinking about it with foresight, they're checking on Wednesday or Thursday. Because if on Thursday everything looks great, technically, we routinely will take a trigger shot to time ovulation approximately 24 to 36 hours before an IUI. So if an IUI is going to be, let's just use Friday for a minute. If IUI is going to be on a Friday morning, you could be taking a trigger shot, Thursday morning, or taking a trigger shot commonly Wednesday night for that Friday morning. But technically, the American Society of Reproductive Medicine, so ASRM, that gives us the guidelines. We don't need it because it's obvious, but they give us the guidelines and they tell us, you could technically give a trigger shot up till the same time of the IUI, up to the same time of the IUI. And that's still kosher, right? That still works. You're not necessarily compromising a cycle. Why? The reason is because we just want to make sure that sperm is introduced for sure, prior to ovulation. Now, if you're really doing it at the same time, it's cutting it close, but it's totally acceptable. And so you have to think about how successful is this IUI going to be? What's the percentages, right? And what is the likelihood and why are we doing it? And how many cycles? What number cycle is this? In a scenario where someone's doing an IUI and God forbid, lo alinu, it's her only opportunity for pregnancy and she has absolutely no eggs. And this is the only time in 3 years that an egg popped up, and it has to dafka be on Shabbos because that's what it shows us from the blood work on Friday and you couldn't check Thursday. That's a different story, right? That would be the case that we would say, we're so sorry, but your body's ovulating today. This is a once in a lifetime opportunity. We got to do it tomorrow, right? That would be a scenario. That would be a scenario. But in most cases, you can see someone on Wednesday or Thursday. You could take a trigger shot Thursday for an IUI on Friday, and ovulation's happening on Shabbos, and you're not compromising anything. It's completely, completely fine. So most of the time that's happening only if, it really looks like nothing was happening on Thursday. And then when you see them the next day on Friday, ovulation is starting. Still, even if it's starting, you can usually do an IUI on Sunday without compromising anything. It's a very small window, a very, very small percentage where it actually would need to be on a Shabbos.
And I don't know what the policy in your center is. Do you do two IUIs or an IUI and then tell the couple to have relations after? What's your
We
approach
do,
when it comes to an IUI?
we and almost all at this point do one IUI. There was a very common practice, even up till about 5 to 7 years ago, to still be doing two IUIs, or to actually rather, most people didn't just routinely do two. That's a lot. They would do one and do an ultrasound, and if you still see the follicle, do the IUI again the next day. There was pretty big studies done on that, and it really disproved the whole thing. It showed that if someone was going to get pregnant, they got pregnant with one IUI. If they were not going to get pregnant, they did not get pregnant, even with two IUIs. And so even if someone is wanting to do that, or at a center where they are doing that, I certainly wouldn't think that, I wouldn't recommend someone, trumping Shabbos to do a
Yeah, for
second
sure,
IUI.
for sure, for sure, for sure. Now, continuing the Shabbos conversation, you mentioned you mentioned the injectables, you mentioned the trigger shot. Let's take a moment, and this is also relevant for an IVF conversation, which we haven't gotten there yet, but it's just so relevant. I get this question every single week, and I'm sure you get it every single day. And that is your injections come Friday, come Shabbos. The injections that we're doing in anticipation of the IUI or anticipation of the IVF, which again, I'm sorry that we're jumping the gun because we haven't even gotten to IVF yet, but let's just talk about injections for a minute. From a medical perspective, some people want to they want to take care of their injections before Shabbos, and then they want to do their injections after Shabbos. If the doctor tells them to find a time and stick to that time every single day of your cycle, so sometimes if they pick, let's say 5 o'clock, so sometimes 5 o'clock will be before Shabbos. Let's say now 5 o'clock will be before Shabbos, but on Shabbos, it's right between pre-mincha, a pre-mincha shot. So I'll be okay on the front end, but on the back end, it's going to be a problem. And in the winter, vice versa. So, so what's your general recommendation, your policy for patients, in terms of timing the shots, doing it a little bit earlier before Shabbos or a little bit later after Shabbos? And then in terms of the actual injections themselves, can they open packages before Shabbos, like the syringe and whatnot, or does that compromise the sterility of the injection? Can they mix things before Shabbos if things need to be mixed, or does it really have to be done on the spot? Can you give us a little primer, what injections entail and what we can do before Shabbos / after Shabbos, and what really has to be done right before the injection?
Sure. So those are a few different questions. What I'll tell you, I'll try to address just the timing of shots first. Okay. In terms of timing of shots, so maybe what I'm going to say, let me preface it like this. I don't want anyone to ever, chas v'sholom, miss their shots or forget the injections. That's the most important thing, right? Because missing a night in the middle of an IVF cycle for some people might not matter, but for most, it could be a problem. It could be a big problem sometimes to miss a night of injections. Certainly if they're not remembering in the morning and redoing it, it could be a problem. And so I would never, chas v'sholom, want to put someone in a scenario where they're more likely to forget about injections or miss injections altogether. That is the primary reason why us, as well as all fertility centers, tell patients routinely, take all your medications. It has to be between whatever. Put in your time frame. Some people say 6 to 8 p.m., 6 to 10 p.m., whatever. The fertility center and nurses recommend. to the patients. Let's say for argument's sake, 6 to 10 p.m., right? So they say, you have to take your injections between 6 and 10 p.m. or something like that. Take them the same time every night, the same time every night. So maybe this is unpopular, but the reason for saying that is so that you don't forget, right? Take it the same time every night. Because if you set your alarm at 8 p.m., your entire life you haven't been taking injections. Now you are taking injections. Of course, it's on your mind, but you're running around, doing whatever you need to do, and you might forget. So if you set it for the same time, let's say 7 p.m., every single night, your alarm rings, you go take your injections, you won't forget them, you're going to do them, and it'll be consistent. Technically, does it matter if one night you take it 4 p.m. and the next night you take it, 6 p.m. or 7 p.m.? Probably not. And really definitely not. Okay. The reason I say probably is because every case could be a little nuanced. I wouldn't take it hours apart, meaning from that 24-hour mark, depending on each individual person going through IVF and their age, why they're doing the cycle, etc. Because there are times that one of those medications, not the stimulation medications, but the other medication that many women are on, which is called an antagonist, that's a medication to prevent ovulation. So if, let's say, Shabbos is let's make it a 6 p.m. Shabbos, and someone normally takes their meds at 11 p.m., let's say, and they say, oh, okay, I take my meds at 11 p.m. every night because I'm a late owl, but it's Friday night, I don't want to take them on Shabbos, and Shabbos starts at, make it 4 p.m., right? So I'm going to go and I can take my medications on Erev Shabbos at 3 o'clock, and then I'll go back to my normal tomorrow, right? For some people, it might be okay, right? But if you think about that, meaning 24-hour mark is now 3 p.m. after they took that medication to prevent ovulation, and then they're waiting 3 p.m. They're going another like 7 hours, of not having that protection, because this is an every 24-hour medication, right? So it's not a matter of the stimulation medications. Sometimes it could play a role in causing a problem when you're dealing with antagonists or the medication to prevent ovulation. So every case is potentially a little different. Some women are more prone to, God forbid, ovulate. Other people are less prone. For the most part, if someone wants to do medications right before Shabbos and then right after Shabbos, it wouldn't cause a problem, right? Wouldn't cause a problem. You're not causing a problem with ovulation. Again, you might move your shots up a little bit, but if you're doing it before Shabbos and then right after Shabbos, that's only a span of 25 hours. That generally doesn't cause a problem. I don't want to, chas v'sholom, cause anyone to forget their medications or cause a problem, but just to answer that medical question, there really shouldn't be a problem. The bigger question, and that's really on the halachic side of like the permissibility of taking most of these medications, which are sub-Q medications. So,
What does that mean? I'll explain it from the halachic standpoint, but just from the medical standpoint.
From the medical standpoint, is most of the medications used for a IVF stimulation cycle and stimulating the eggs are subcutaneous injections, meaning they're little tiny needles. You pinch the skin, and that little tiny needle goes right under the skin and injects right under the skin. It can cause some bleeding. It is certainly possible to cause bleeding, and sometimes does, and can cause black and blue marks, but most of the time does not cause bleeding at the time of injection.
Which is an important halachic consideration, because as someone asked in the chat, what is the issue over here with injections? So one of the issues with injections is drawing blood. On Shabbos, you're not allowed to draw blood. So the doctor said as a sub-Q, not in the vein, but rather in the skin. If you have an intravenous, if you have an injection that goes into the vein, which certainly draws blood, so that could be a very, very, very big problem, maybe even an Isur D'Oraisa, maybe even a biblical transgression. However, when you're dealing with something which is not in the vein, it's in the muscle, it's in the skin, but not in the vein. So then the question is, does this always cause bleeding? And the answer is no, it doesn't always cause bleeding. So since it doesn't always cause bleeding, and your intention is not to draw blood, your intention is to give the injection, it's not to draw blood. So therefore, that's something called a davar she'eino miskavin. And we paskin, we rule that a davar she'eino miskavin is permissible on Shabbos. And therefore, it is absolutely permissible for a patient to give herself an injection on Shabbos. It is permissible for a friend, a nurse, a husband, whomever that may be, to give the injection for the patient. Some people are machbar, they want to find a non-Jewish nurse to try to do it for them. If you have one readily available, fantastic. If you don't, do not drive yourself crazy, because you can do it yourself. You can ask your husband and you can ask your friend if you don't want to do it yourself. So that is, so that is the halacha when it comes to the actual injection. I love this comment in the question and answer that someone wrote, in my experience as a nurse giving fertility shots, it only bleeds when you do it on Shabbos, never any other time. Okay, Hashem has a sense of humor. So that doesn't take away from the fact that it is mutter. It is still permissible, even if it happens to be that blood comes out, it was still permissible retroactively on the spot. It's permissible because, again, it's a davar shena miskaven. It doesn't always draw blood, and therefore the act is 100% permissible. The other thing, though, that Dr. Abittan, can you talk about the mixing of the meds? Because some meds need to be mixed, and mixing and measuring. There are some issues with mixing and measuring in halacha, and some people ask, can they do that before Shabbos? And from the halachic answer to that question would be, well, if it can be done before Shabbos without compromising any medical issue, then great. But then we throw it back to the doctor and we say, Doc, can these meds be, can the syringe be opened? Can it be assembled? Can it be mixed? Can you do all these things before Shabbos, or do you really rather that that everything is done immediately before the injection?
So that's a great question. Almost all the medications are fine to set up before Shabbos. Really, this would only come up with two medications, primarily. This would come up with two medications. The two medications it would come up with are Menopur, which is a very, very commonly used medication. Almost every single egg freezing and IVF cycle uses Menopur. And that is in a powder form and has to be mixed. The truth is, the company recommends, within 15 minutes of use is when it's supposed to be mixed. That's one of the medications. And the other one is one of those antagonist medications, the medication called Cetrotide. Also is a medication that needs to be mixed. That's a medication to help prevent ovulation. I don't know the true answer. So that is something that I would have to look into. I know what the company tells us, and I know when I've asked them, they've held to their guns, that they've said that 24 hours might be a little bit too in advance to mix the medication. They were not confident that it would be fine. Now, again, and when you speak to a company, they're obviously going to cover themselves.
Right.
I have certainly heard of plenty of accounts of women who have mixed it early, mixed it before Shabbos, and there didn't seem to be any problem, right? But I don't have a good, well-designed study to give data on that. So I don't know. Right. I know many accounts of women that mix it before and have no problem. Again, this also shouldn't really cause too many problems in terms of measuring. It shouldn't cause too many problems because the way the Menopur comes, at least I'm going to ask if this does still pose a shiloh of measuring, but the way Menopur comes is you have a little vial with powder and then you have a little vial with fluid. Now, it happens to be that there are 2 milliliters of fluid. You only need to use 1 milliliter, but let's imagine that you just draw up whatever you draw up. It doesn't even matter. Actually, you could draw up any amount of fluid, mix it into that Menopur, squirt it around, draw it back up, and then you're injecting. So I don't know if, I'm just wondering if that would cause an actual problem of measuring or a problem of mixing, since it's really just powder and it's still becoming a liquid. So I don't know, but unfortunately, I don't have enough data and hard facts to be able to answer that question.
Right. So therefore, so what does the Rav do with that? So when that's what the Rav hears, so in the Rav's mind, from the halachic standpoint, so that means, well, we don't have a doctor telling us for sure it's okay. You don't have a doctor saying for sure, don't worry about it. This is just, precautionary. No. We don't have a doctor confidently saying that. And since we don't have a doctor that's confidently saying that, so we would not recommend a patient to open up to mix or to measure things out before Shabbos. It's not worth it. In terms of the actual measuring or mixing, these things are only a potentially rabbinic in nature. And the patient over here is what's called a chola and a chola in halacha. And it's maybe even letzorach mitzvah for puravu. So medida letzorach mitzvah is mutter. You're allowed to measure things for mitzvah purposes. So we have so many reasons to permit it. And therefore we do tell patients all the time that it is permissible to do the injections on Shabbos and to prepare the injections on Shabbos. If they can tear the gauze pads before Shabbos, okay. When you're doing the air, when you're wiping the area, try not to squeeze the what do they call it? The wipe, not to do schita on the wipe. But other than that, I think that really covers all of the questions when it comes to injections. We
Well,
really
there's
only
one
have,
more.
yeah.
There's one more that is it could be a bigger shaila, which is when a couple or when a woman is doing an embryo transfer, she frequently, not every single style, but let's say 80, 90% of the time, you're taking some form of injectable progesterone. This progesterone is a different style injection. So this is an injection into the muscle. And some women are doing this daily. And some women are doing this, every other day or every 3 days, but not less frequently than that. And this is a, muscle injection, which might or may not change the halachic status. But if someone's doing it daily, you can't miss a day. This is something that's actually way more important than missing injections during an IVF cycle, is missing this progesterone, which is pretty important. Now, we can play around with it. I always tell women, it happens to be in my center, we actually do it in the mornings, but sometimes if you do it at night, it's easier because you could just take it a little early and a little bit late before and after Shabbos if you don't want to. But that is something that's extremely common for basically everyone that does IVF.
The truth is, it doesn't really change. It's not into the vein; it's in the muscle. I have to be honest. There is a sefer called Nishmas Avram, the Nishmas Avram, which is an amazing work on medical halacha. So he writes there that he thinks it's problematic to do it on Shabbos. However, I remember seeing it. Actually, the truth is, it's one of Dr. Abittan's patients asked me the shayla, and I said it's fine. And then he called me right before Shabbos. After Shabbos, I live in Los Angeles. This patient lives in New York, and I opened my phone on Motzei Shabbos, and I see that he had texted me pictures of the Nishmas Avram that said that it's Aser. And I couldn't believe it because I didn't understand why that should be. And I started to look into it. And I Baruch Hashem, I saw many, many other later day poskim question that psak of the Nishmas Avram. Why should it be Aser? It should be like any other medication. It's not going into the vein. There's no problem of drawing blood. It's necessary for the patient. The patient is a chola. So really, my psak stands that progesterone injections are totally mutter, and if they have to be taken on Shabbos, they can be taken on Shabbos. The question just came in: is it permitted for them to give the intramuscular injections on Shabbos? The answer is yes. Okay, my friends, we only have 10 minutes left, and we haven't even gotten through a lot of what we wanted to discuss. Let's just talk about IVF for a minute. A couple has not been successful with their IUIs. They're going to IVF. We discussed sperm in terms of how we get the sample, how we obtain the sperm sample. Can you talk about? I'm just trying to think. With only 9 minutes left, I want to discuss supervision, because we have Rivki Itzkowitz, who's the head of supervision here on the East Coast, and she does so much work at Extend Fertility to make sure that there are observers, there are mashgichot present to observe not just the IVF, but the IUI cycle that we spoke about earlier. When, Dr. Abittan, can you talk for 2 minutes, actually 1 minute and 47 seconds, about your experience with hashgacha and what it does for the patient, not just from a halachic standpoint, whether they need to be or not, but what does it do for a patient that you see, being the doctor and knowing that there's a mashgicha there, a poor mashgicha standing, making sure that everything is done, looking over your shoulder, but not really. Tell me from your perspective.
I love it. I think it's fantastic, but I'll tell you my perspective of the patient side. We're not okay to see Rivki Itzkowitz right now, but I can tell you that she works mamish day and night. I don't think she sleeps. She's always working for patients and mashgichot and organizing things and just turning the world over to make things happen for patients. And so we see this on the other side. This is a challenging environment to be in. Many times you're young and you're dealing with some sort of fertility issue and you're going through a problem. Certainly if you're involving hashgacha, then that means that something is coming out of the body and it's going into the lab. That could be sperm for an IUI, that could be eggs, that could be IVF, whatever exactly is going on, you're in a vulnerable position. And you're here with, doctors and nurses and embryologists, and you're having procedures done potentially, and it's very scary. But you have a mashgicha there who's asking for your name and is saying Tehillim, and she's wishing you hatzlacha, and you can visibly see that patients, the amount of appreciation that patients have, and the calm and serenity that it provides. Of course, there's also the halachic side of things and the hashgacha side of things, and everything that they're doing is fantastic. But just on the person side of things, it does so much for this patient that's going through this challenging time and is nervous and is scared, to have someone who cares about them, who says, I'm going to be watching everything, and is giving them brachas and saying Tehillim, next to whatever's happening. It's fantastic.
It's the best. It's the best. So a patient has a retrieval. You mentioned earlier that some of the big challenges that you encounter are things related to Taharas and Mishpacha. Let me give you a very, very, very classic question that we get very often, and that is mikvah post-retrieval and mikvah post-transfer. So very often you have the cycle is set up in a way where the retrieval takes place after she goes to the mikvah. She went to the mikvah, now she's tahora, the couple's together, fine, she has her transfer, she has her retrieval, they take the sperm, they make the embryos, beautiful, hopefully everything is great. But sometimes the timing is a little bit off, sometimes she bled a little bit more than she anticipated, and she doesn't get to the mikvah on time for the actual retrieval. So the retrieval is today, what's today? Tuesday, and my mikvah night is tonight, Tuesday night. So patients ask, am I allowed to go to the mikvah shortly after a retrieval? And similarly, my transfer, fast forward, different case. Next month, come back for the transfer, 2 months from now, whatever it is. I come back for the transfer. My transfer was this morning, but it's also my mikvah night tonight. Can I go to the mikvah? And if not tonight, then when? Can you tell us a little bit about mikvah, post-retrieval and post-transfer?
Sure. You're getting me to say all the things that I don't like to say publicly that we just
Did you think you were going to get off the hook tonight, Dr. Abittan?
Yes, actually. Okay. Again, I don't want to make blanket statements that are going to be, revolutionary, but when it comes time to mikvah after retrieval, so let me explain what happens at a retrieval. What happens at a retrieval is we do an internal ultrasound, and there's a little tiny needle the size of an IV that makes a tiny hole transvaginally, makes a tiny puncture directly into each ovary. So one puncture on each side, okay? There might be a little tiny bit of bleeding or spotting afterwards. In general, that stops. It could be a little bit more than that, but usually that stops, and that shouldn't cause, any major shilas. There's no bleeding from the uterus. There's no issues, but there is, bleeding from a little puncture in the vaginal area. Now, because of that puncture, technically, there's always a chance of infection, right? We just did a procedure, and now there is that little tiny puncture. And if anything is entered into the vaginal area, hypothetically, there could be a chance of infection. Because of that, pretty unanimously, anywhere you are, they'll pretty much tell you, like no intercourse or anything for like 5 days or something after a retrieval. That's pretty routine, I don't know, nomenclature that you're going to find in the paperwork, and that's probably what the nurses are telling you. That night is probably not a good idea, because first of all, you also do have a fresh little puncture, and there could be a little spotting, etc. It's probably not a good idea. Keep in mind, retrievals are usually in the morning. So let's imagine your retrieval is Tuesday morning. So probably Tuesday night is not a good idea. If mikvah night is Wednesday night, it's probably okay. You're talking about 36 hours later. There's no spotting, there's no bleeding. That little tiny thing closes by itself. I wouldn't, sit in a bath for 3 hours. But as long as you can minimize the time that you're actually submerged, there really shouldn't medically be any problem. Okay, I don't like making that blanket. You never know what could, chas v'shalom happen, but I would be exceptionally surprised if someone would ever chas v'shalom have an infection from a very quick dip in a mikvah, 36 hours after a very uneventful, safe, clean retrieval. Most of the time, you're taking some form of antibiotics anyway, usually taking some oral antibiotics, which is common practice. And so that's when a patient specifically asks me, says, I know it says X, Y, Z, but mikvah night's tomorrow, I'll say, listen, if you, don't sit in the water for a long time, ask your Rav what's like the minimum that you're able to do, and you make a quick dip, it really shouldn't cause a problem. Everyone's different, though. In terms of a transfer, I'll tell you what we say, because of lack of evidence. There's no evidence that intercourse before or after, a transfer should cause any problems. We know that once an embryo gets placed in, it usually floats around for about 24 to 48 hours until it implants. Our bias or thought process is it's probably safest to limit intercourse to after those 48 hours, meaning the 2 nights following a transfer. That's what we usually recommend, not because of data, only because we know that implantation doesn't happen for about 24 to 48 hours, and we're just nervous about that, okay? We also recommend the night before to potentially also not be together to limit intercourse the night before and the 2 nights following a transfer. That being said, there was an interesting study that came out about a year or two ago about intercourse the night before a transfer that seemed to think it was, improved outcomes. It was a small study. I'm not giving credence to it. I'm just mentioning it in case someone was looking that up and says, what are you talking about? So there was a study out there. We usually would recommend just the night before, because again, we want to keep everything clean, sterile, perfect. We're going to be placing an embryo in. It's going to be sticking in the next 24 to 48 hours. So the night before, the 2 nights after to refrain from intercourse, anything before and after otherwise is totally fine.
Amazing. Amazing. The time is up. The time flew by. We didn't even get to egg freezing. And I see that there are a few questions in the question and answer box about egg freezing. The truth is, although we didn't discuss egg freezing as a topic in and of itself, a lot of what we discussed is very relevant to the egg freezing discussion. Namely, a lot of the questions that come up with egg freezing is regarding injections the week before the Shabbos or the Shabbosos before the actual egg retrieval. So we discussed the halachic perspective and the halachic protocols regarding injections. We spoke about supervision and having supervision there, not just for the IUI, not just for the IVF, but for egg freezing as well. For egg freezing, we discussed if your IUI falls out on Shabbos. We didn't discuss it about IVF, but thankfully we've worked with Extend for so many years, and the cases of going into Extend on Shabbos are far and few between. So really, they do a very good job. And most doctors, you tell them in advance that you're a Shabbos observer, you're a Sabbath observer, you want to avoid a Shabbos retrieval at all costs. Generally speaking, they're very good at manipulating and planning the cycle that the IVF, whether it's an egg retrieval for egg freezing or for IVF, that it shouldn't take place. It shouldn't take place on Shabbos. So the same thing is really true when it comes to egg freezing as well. And for the most part, those are the questions. I see here, there was questions about.
There are some questions. I think it needs a whole webinar in and of itself, which is really a webinar about genetics, genetic testing of embryos, what to do with additional extra embryos when someone has such a bracha to have extra embryos in the long run. So those are a bunch of these questions here about inviable embryos and or extra embryos, halachas around testing embryos. That really needs a whole session in and of itself. Big topic.
On a very basic level, because I love all of our listeners and I want to be able to address all of it. We do paskin that you can discard unviable embryos, things which are never going to be used. Certainly embryos that are aneuploidies. If you have abnormal embryos, you could certainly discard them. Halacha doesn't recognize an embryo as a life, so you could discard it. It's not a problem. And a lot of the post-testing, the embryo testing, the pre-implantation testing that's available it's an interesting discussion. But bottom line, it's more of a medical question whether it's a good idea to do it, whether it's not a good idea to do it. Just today, I spoke to someone. She's 43 years old. Do they do the testing? On the one hand, advanced maternal age, there may be a higher risk of trisomy 21 and other Down syndrome and other genetic issues. On the other hand, if they have so few embryos, so then maybe the testing will come out that the embryos are abnormal, and then they won't have any embryos. So then, what do you do? It's a good question. It's more of a medical question, more of an Eitzah question, which Pua will be happy to help you with, as we do always. And so very often we have this question. But from halachic standpoint, testing the embryos is permissible, whether it's the pre-implantation genetic testing in that sense, or other genetic testing, which is important. We encourage it, and often it's very, very helpful. I thank everyone for coming. The attendance was really spectacular, and I hope that everyone found tonight's webinar informative and really inspirational. really inspirational, because coming together, such a large group of people to learn about the medicine and the halacha and to hear from experts like Dr. Abittan, it's a real schus for us. So wishing everyone an amazing night, wishing everyone hatzlacha rabba on every, wherever you are on your journey. Keep up the great work. Be in touch with Kua, be in touch with the doctors. And we wish all of you bracha and hatzlacha in your journey. Take care, everyone, and have a wonderful night.
And thank you so much for the opportunity.
Take care, everybody. Thank you, Dr. Abittan.